started on today, I'm really excited to welcome Dr. Brooke Cunningham as our opening keynote for this event. Dr. Cunningham was appointed to Commissioner of the Minnesota Department of Health just earlier this year in January. Prior to that appointment, Commissioner Cunningham served at the Health Equity Bureau, overseeing the Center for Health Equity and the Office of American Indian Health and other DEI efforts. She is a general internist, a sociologist, and an assistant professor at the University of Minnesota. So I am really excited to begin this conversation. So I'm going to move over here. Thank you so much for joining us. I'm going to start off with a question, and we'll kick it off here. You have been in this role for just about a year. As you look forward into 2024, I'd love to hear kind of what your most critical issues you think are in front of you as the commissioner and in front of the state of Minnesota.
Thank you. Well, let me first say that I'm happy to be here. The State of Reform, that sounds like a great title of an organization. I think we are in a moment where we can really think about health and healthcare transformation and the things that we need to do differently as a field. So going into 2024, we have a lot on our plate from 2023, to just be frank. Of course, in Minnesota, we had a historic budget. We had a $17.5+ billion budget surplus. So the state was able to do a lot of good work. We really increased the budget for the Department of Health. As you all in the health space know, both nationally and in Minnesota, public health is a relatively small percentage, somewhere between 3 and 5% of the total health budget. But we also know that many of the challenges that we see can be averted by investment in upstream preventative effort. So 3 to 5% of the budget, we need to go bigger. And the Department of Health was able to do that in some core areas that are key for me even as we go into 2024. Because for us in Minnesota, we have a biennial sort of budget cycle. And so our main budget proposals are in the off years. And so we had some big major investments for the Department of Health in things like family home visiting and early childhood development and addressing substance use. The opioid epidemic is really challenging us. It's tied into the mental health crisis, like every community-based organization and even healthcare organization, like every space that I go into, people really talk about mental health quite a bit. We do the Minnesota Student Survey, and we are seeing very high numbers of Minnesota young people reporting episodes of depression or thinking about suicide, some of the highest that we've ever seen. So really investing in those spaces and implementing, making sure we get off the ground the things that we put forward, because we really do believe things like that substance use proposal, things like 988 for mental health that we're going to expand to include chat and text capabilities, things like the Office of, you mentioned the Office of American Indian Health. So I came into the department as Assistant Commissioner for a new Health Equity Bureau. The department had long-standing efforts in the equity space. Unfortunately, our department is largely grant funded, right? And so 60+% of the monies that come into the Department of Health for our efforts actually come from the federal government. And so things like that are funded and got funded through COVID that were really important and impactful for our COVID response, as COVID dollars ended, as grant dollars end, those programs would go away unless we got them in the base budget. And with the surplus, we were able to get things like the Office of American Indian Health into the budget. We have disparities in Minnesota, like many of you all have disparities in your states if you're not from Minnesota. In Minnesota, again, they often affect Black and Brown and Indigenous people. For substance abuse, American Indians have 10 times the rates of fatal and non-fatal substance use overdoses. So having the Office of American Indian Health, investing in a new Office of African American health, because the other group, again, that comes up repeatedly over the course, probably everywhere across this country in terms of looking at gaps, are Black Americans. So we invested in those spaces as well. So we have a number of very important new initiatives that we've got to move forward, including in the core health policy space around healthcare affordability and costs, and there's an equitable care task force. And so a lot of good work, but for me, 2024 has to make sure those things launch successfully and get their foothold.
So as you move forward in implementation, particularly let's stay focused in the equity and disparities arena. What do you see as some of maybe the programs that you might engage in, or how are you going to use the investments that you see so far in forwarding that topic?
Right, and so in Minnesota we have, in some states there's a mega agency, right, that is Health and Human Services, right? In Minnesota, Department of Human Services, and you'll hear from Assistant Commissioner Connolly later, right, is our Medicaid agency, has done things around vulnerable Minnesotans, children or elders, does direct care in the behavioral health space. In my space, we are again largely about data, largely about health data, community convening and collaboration, grants out to community-based organizations, and then regulation. So regulating hospitals where CMS's arm and assisted living long-term care settings. So when we think about disparities, again, those investments that I talked about are important. In the data space, I will just lift up one thing that we had through the legislative session that people have, again, been calling for years. And actually, when I came to the department, they pulled out a report from 2014 about data disaggregation. Because these big groups, right, Black, Asian, these big racial groups have such diversity within the groups. We do ourselves a disservice when we lump everybody together. And so the Department of Health has undergone extensive community consultation to say, and work with the state demographer's office to say, really, what do our demographics look like? How do we get demographic data that really reflects the diversity of Minnesota? And then with the state budget proposal, the idea is that agencies will collect similar variables around demographics. So we can share that and have synthesize our work and have more impact. So I think that is really, really key. I cannot overemphasize how important that is to really understand and address population health, right? Because different communities have different stories that create health risk and health protective factors. And so if we can get under some of these big labels that we look at people, or if we can think about place, because I will also move forward, and this is one thing that I push at the department. I'm trying to have a conversation about social epidemiology, but if we can also think about the race effect that we see, as we know, that is not a biological effect, that is a social structural effect. And so with our science, how does our science reflect that? And so one thing that I also push is let's look at place-based metrics, right? And that's really critical for operations. It is easy to go to a place, and we shouldn't and it helps us not make assumptions. So, and the other thing that I would say, just when I think about new strategies to advance equity, when we think about partnerships, I really do see in the forecast, and it's being talked about, so it's not like I have a vision, but it's being talked about, right, where clinical data, so our electronic health record data, our Epic data for our systems, I was in a meeting and somebody said, we need the epi in Epic. And that is for real, right? Because that clinical health data, as we add other fields to that data, particularly around social determinants of health, how our healthcare systems who cover more of the population, we have the Electronic Health Record Consortium, which helps us with a lot of our COVID data, a lot of breaking down our data by race and ethnicity. They have been so helpful because they cover 90% of the population in Minnesota. And so those sorts of partnerships are really important. For me at the Department of Health, because I'm not in a mega organization, usually it is the Human Service Society or the Medicaid agency that has the ability to go and advocate for those federal dollars to invest in data and in clinical data infrastructure. For me at the Department of Health, I have to work with folk like Commissioner Conley, and certainly his boss, Commissioner Harpstead, to really make sure public health has a place at the table if we forecast using clinical health data as public health data in the future. So there are a lot of opportunities, the investments from the legislative session that I've mentioned, but also these opportunities on the horizon with working together across the state with similar data indices, working together with healthcare systems, with electronic health record data, and then really fleshing out partnerships with those partners as well as with community-based organizations about strategy.
I want to come back to the partnerships in a little bit. I want to ask you if you could pick among your many programs. Can you tell us something that you're really excited or proud of that you did this year?
All of it.
Yeah, all. See, I knew it would be hard.
I mean, I will tell you, I come from, as you all heard in the bio, I come from I was assistant professor at the University of Minnesota. I was on the clinician investigator track. I got what I was supposed to get, which is a K award, to launch me to try to get an R. Am I talking people's language? Anyway, so some of you all know what I'm talking about. But, you know, and I just came from a conference from their Clinical and Translational Science Institute last night. And I think I was getting antsy as an academic. We need data. We need that core, reliable, accurate, robust information to make choices. But I, in that role, was getting a little antsy about action. And so coming over to the Department of Health, and particularly coming in last year where I, even as assistant commissioner, was able to lobby, right? I can be, when I want something, I can come at you and talk to you. I mean, honestly, even the disaggregated data conversation, that happened because I kept, in many ways, bringing up, the department had done the work, and everywhere I would move, I was like, we've got to do this, we've got to do this, we've got to do this. And so having, you know, being the loud voice, the squeaky wheel is helpful. But coming over to the agency, what was fantastic at that moment was we had such opportunity to move things on the equity agenda. So I am proud, if I have to pick one thing, it is very tough, but I'm gonna pick from the portfolio of things that I had something, a little piece of for the legislative session, which would be our equity portfolio. And I mentioned an equitable care task force. So in Minnesota, we have the great distinction of always coming up like in the top 5 for like healthcare quality, right? Healthcare, we have one of the, you know, best statewide healthcare systems, but we also, you know, we also have a bad side. There's an underside, which is we also come up high in disparities and racial disparities specifically. And honestly, I am really tired of saying we have some of the best healthcare in the country with some of the worst disparities, like holding both of those things at the same time. And my work as an academic was really like, we know the data, like these disparities are not new. We know the historical and contemporary factors that contribute to racial disparities, and we've known it for a long time, right? We've known it for a long, there have been reports, like I think since the 80s, right? And so we have known it for a long time, and as an academic, I was like, we know it, and so why in healthcare have we been so slow to move on it? If you look back, I think it's the Hackler report, I'd have to get it. I think it's the Hackler report, like from the Federal Department of Health and Human Services. It talks about, it's like Black and minority health, or minority health in the title. I believe it's from the 80s. Like, again, we know this, and I'm sure there was a report before that. And so what I'm most proud of, this long answer, is this equitable care task force. Because my research as an academic was, what are the barriers that we are not doing this work in healthcare? And so what the equitable care task force is designed to do is to bring together all of the stakeholders, the interested parties, both from community and focusing on Minnesotans disproportionately impacted by health inequities, and from the payer side, and from the healthcare side. I've got to check if they've published who's on the task force. I would tell you, but I'm not sure if it's out. But we're gonna have some great leadership in that space, and and the charge for them will be to let's think about the system levers. Like, again, I'm almost as tired of talking about training. Training is important. Implicit bias trainings are a good start. But they are the least that a health system can do or a healthcare community can do to enact change to address inequities. We need healthcare systems to be at the table thinking about the policies. So when Connolly comes here this afternoon, and I hope he talks to you all, and you all already know in this room about certain things that come out, opportunities from CMS. CMS has these pilots around models of care that they hope will reduce health inequities. These are pilots that are not about training frontline staff, right? These are about system change. These are about payment change, right? And so what are the system levers that we need to leverage, both at the micro-organizational, what is our system, like what do we need to do as a system? Like how can we actually get Saturday and evening hours? No provider likes that. But how important that is for Minnesotans who just can't get off work, right? Like Monday through Friday, 8 to 4. I barely made, right, because my daughter got to get on the bus, right? So the 8 to 5, I need a COLA. I can't, and I am, relatively privileged. I'm sitting up here as Commissioner of Health. But like, what are the things that we have to do? And again, we're in a moment that COVID hopefully has taught us a couple things, right? It taught us that we could pivot and we could act relatively quickly when we came together and we put all our heads together. And it taught us that we could pivot, and it taught us the importance of collaborating with community and being really focused in one direction together. So let's use this moment, including where health and hospital systems are under stress, and it's very hard to think about the future when you're under stress, but part of the stressors are also because of the challenges that Minnesotans and Americans have in our current system with staying healthy, so people end up in the hospital and end up in the ED.
So in thinking about, you said several times in terms of opportunities, CMS opportunities, the funding that's come through, and the example that we have of what we can do.
Right.
What do you see stands most in the way of forward progress? What is the biggest barrier from your perspective? Since you have some resources, you have some opportunities, what are you most worried about preventing further progress?
So it's interesting coming into this space. I don't know that I'm most worried about it, but it is a reality that, there are always competing priorities, and they're different political interests. And unfortunately, when you talk about equity specifically, sometimes it's hard for people to see the benefit for themselves, rather than for folk that they see as others, right? And so I think those are some of the challenges, the stresses in the system right now, again, in terms of focusing on transformation when people are really hurting or facing, the workforce shortages. It's hard to focus on transformation. At the same time, how do we flip that into the opportunity? And so we need the leadership at the table to help, yes, deal with, it's hard to put out the fire and build the new thing at the same time, right? Because it's not even, people say flying the airplane, but the airplane is the airplane, you're not just flying it, it's a little bit on fire. But that's why we need to think really again, there's so many good things when I think about the payment question and the reimbursement question. And we also have to think about what we need to let go of. That's what I say to my staff. Because my staff is stressed. They're stressed. I don't help, I really don't. I try to help. On one hand, I try to help with the organizational health, right, and well-being and thinking about our culture. On the other hand, sometimes I don't help because there's still some remaining COVID dollars that we can get reallocated, and I'm like, let's go get that money, right, because I don't know that we're gonna have a $17.5 billion surplus again. But what I hope we will do also in the moment is, as we're doing all of this work, is to really have that focus on policy. Because what I also say to folk at MDH is we need to work ourselves out of a job. You know, and that can only help if we shift in other sectors. Because MDH public health is terrific. We're largely focused on, philosophically, we're largely focused on the upstream social determinants of health, and we feel a challenge because we're not the Department of Ed. I'm not DEED, Economic Development. You know, I'm not housing, right? And yet all of these factors shape the context and the constraints that people have to live through to get their health optimized. I think the one thing about the Walz administration that is helpful, and this is what we need to see across the healthcare sector, is they try to put tables together where all of the agencies can come together. And we also need that, across the healthcare sector. We're sitting in downtown St. Paul. I moved to Minnesota in 2013. I was learning the area. I noticed the disproportionate placement of clinics. I will just say, I don't know how many how many Minnesotans are here? Oh, most of Minnesota. Okay, how many metro people? Oh, most, okay, so you all will know. Okay, so I came to Minnesota. I came into St. Paul, and at this point they were talking about community benefit, right? And every hospital has to do their community benefit for their, for their taxes, to get their tax break. And it was fascinating to me down here. You all know better than I do, because I live in Minneapolis, and until now I've worked in Minneapolis, but it's like St. Joe's, United, Regents, like it's so, the concentration like right here. And I was like, do folk work together on this community benefit thing? And I hope it's different 10 years later, but back then it didn't seem like folk did. But everybody is serving the same community and catchment of people. And so bringing folk together around the table, seeing folk, because we're all in it with the same goals and mission, even if we are competitors. But, we all want to promote the health of Minnesotans. So anyway, I don't know if I answered your question, but okay.
Well, there's a lot of good points. And there is an opportunity for you all to ask questions as well in a few minutes. But since I have the mic, I get to go first. So I think you've been talking a lot about this last point about partnership particularly. Yes. And the internal partnership that you described between the departments. I want to hear a little bit more about that. But then also, how would you like to see that play out in the community? Since you do have a lot of people out here who play different roles in this market, I use that term, market, of the state. We'll go broader. Any thoughts about who needs to come together and how to create some joint purpose?
Yes. So public health needs to come together with healthcare. And, we are, I think there are 51 county health boards, which oversee a number of local public health agencies. Some county health boards are just a solo county health board. Some are multiple county health boards. And a lot of you all are from the metro, right? In the metro, we've got Hennepin County, we've got Minneapolis Public Health, we've got Bloomington, I think we've got Richfield. So there are a lot of local public health agencies which are the boots on the ground, in addition to our department at the state, which need to be partners, right? And so we, one, need to create the table within public health, and that is happening, because there's always a dynamic probably between the state and local institutions, right? Because understanding, and I would say this, I say this for community-based organizations, folks closest to the community have their pulse on what the community needs. And so that plays out between state and our local partners. And so we are working together to make sure that as we have to address the foundational capabilities of public health, that we also have flexibility for local public health groups to implement those activities in ways that make sense for their residents and their people. And I will say, some local public health departments are actually nested within a hospital system. But most of the rest of, many are not. In the metro, it's not. And so we need to be very intentional about making those collaborations happen. The Institute of Medicine in 2012 wrote a report about particularly primary care in public health. I think something like that needs to be re-upped. But we need those health care tables. So it's been now almost a year and 9 months since I've been on the state side. We need more of those tables. I've gone into meetings, but I really think, and I was talking to Jody Harpstead at one point about how do we create that table. And some people will be like, why, do we really need another table? And I really do think that we do. Like the Equitable Care Task Force will be a great table, but I do think we need some other table where we can group think together about solution and strategy. And then the other thing that I've been asking people about, because apparently there had been a healthcare action table, maybe pre-COVID. I talked to Jennifer Lumland from Stratus about that, as I'm like, where is the table? And it sort of, again, as many things went sort of defunct with COVID and now has time to reemerge. And so we should, with intention, reemerge that table. But I also want to think, there's so much work to do in this space. I also am very curious about where is the Chamber of Commerce table. If anybody here is from Fortune 500, businesses who are their own big group purchaser, employer-based health insurance, which most of us, I will get the statistic wrong, but I believe it's high 80s, or around 80%, I think. Somebody will correct me here about the number of Minnesotans who have their insurance through employers. But we've got some big group purchasers that are not public purchasers. So county purchasers are big purchasers. The state, CGIP, is a big purchaser. But I have to think our Fortune 500 big employees are big purchasers. And how can they think about population health beyond just the population of their employees? How do payers think about population health beyond just the population of their members? Hello? When I came in 2013, and I was a postdoc at Medica's Research Institute at the time, and the buzzword at the time was population health. I heard community health. And then I went to, there's a population health director. I'm so excited because I heard community health when I heard population health. And I went and talked to that person at the time, and it was, our diabetics, our member, and I was like, So I'm talking about big P population health, right? And so how do we get, whether it's payers or Target and, General Mills and 3M and Caterpillar and all of them at the table also around population health. They have health folk in leadership roles in those organizations. And so we need to think with them, as well as probably, to be honest, as we're seeing shifts in the healthcare marketplace, we got to also think about things that we're seeing happening, right, in terms of the investment of venture capital into certain spaces, and what we think, how are we going to position ourselves relative to these changes, right, in the healthcare space.
And certainly partnerships are your opportunity for sustainability, right?
Yes.
I mean, you've got some funding now,
Yes.
setting up those tables and getting those conversations. I've sometimes heard large employers around population health referred to as sort of waking a sleeping giant.
Okay.
They don't spend a lot of time on that, and yet this is a real opportunity. So good luck with that. I think.
Well,
it'll be a lot of
however
fun.
we frame it, I mean, right, like, because we're going to have, the other thing, there are workforce shortages for us. We talk about that all in healthcare. They have to be focused not only on their labor, as people as labor, but also on the well-being, right, of employees. And so, yes, it's fantastic to have my employee wellness program and try to get my points that I never get, right? I never have time to get, but like, for whatever corporation that we would pick, to replenish employees as boomers, et cetera, and other generations retire, they've got to invest in the educational system. They can't be in a state, with huge educational disparities where you look at whatever, and again, I wish I had these, there was some astounding number to me of, elementary school students who were not meeting reading and math proficiency. And of course, disparities in that state. For the vitality of not only their workplaces, but for the state, they've got to invest in these upstream. It is in their interest, and good luck to me, but I have to think that somebody, if it's not me, that somebody will have their ear and say, this is in your interest.
Well, and I think your point about data
Yes.
is part of what's going to help with that, right? And part of that argument. So certainly.
Data is important, but I will also say I have an essay on my computer that data is not my black girl magic. So, and this is part of the reason. I think the essay is if only data were my black girl magic or something like that. And that's part of my shift from academia. Because again, back to my first point, we've had the data. We need the will.
Totally agree. Well, this is an opportunity for all of you to ask any questions if you have thoughts or things that you want to hear from the commissioner on. And while people are thinking, I have one more question, but let me give it just a second. I can be a little patient. Oh, we have one here. April, right up here. Thank you.
Hi, Commissioner Cunningham. My name's Savannah, Cleveland Queen with Find Help. I really appreciate all the insights you provided today. You mentioned so many wonderful points, and I'm going to really try to be concise with my question. But the data's been around for a while, and we know that change happens at the speed of trust and relationship. And we also know, as you mentioned, competing priorities. So how do you, as the commissioner, what is your recommendation for how we keep various players engaged, those stakeholders, especially when we know that these changes aren't going to happen overnight because the disparity didn't happen overnight? So we'd love to hear long-term recommendations that you have and how to keep people engaged.
Yeah, as I think about engagement and also as I think about trust, to that other piece of your question, and as I think about equity, is that we've got to continuously show up. Part of my challenge, which I love coming into conversation with people, and part of my challenge as commissioner is because I want and recognize the need for cross-sector, cross-community, greater Minnesota Metro, all people to really do some radical inclusivity. Part of my challenge is bandwidth. I am fully intent, and I have to distribute the load, right, to show up. Right, and I think showing up is important because it takes a long time for that engagement to happen, for people to sort of come to consensus, for people to align. I will say when I think about equity in particular, part of sometimes what worries me is that we go, because there's so much need, that we go so thin. And so when I think about these tables, if we could continue to come into conversation and say, well, here are the 1 or 2 areas that we're gonna go deep, hey, right? Like, hey, in our grant making people, including the Department of Health, we're gonna go deep, including foundations from, all of the entities that I said. We're gonna go deep in the same places, right? Healthcare, we're gonna go deep together. Maybe it's 5 things. But even coming to alignment, because again, there's so much need, and it's not to stop action in other sectors, but for, again, back to what you're saying, because part of what's under both these questions is about prioritization. And I really was thinking about that literally because again, sometimes I stress out my teams, right? And so I was like, how can I do less of that, right? And part of it is helping them to prioritize. But again, there has to be consensus building. There's stuff that I need to understand. But what is the most impactful thing that we can do now? And then what do we actually need to do now so that we can be ready for the future, right? That is where my informatics focus is, because I was like, we need to do stuff now so that we can be ready for the future. But also, yes, we got to go deep on substance use because people are dying. And so showing up and sticking with it and continuing to make space so that people can show up. And if it's not you, who can show up, who is aligned with you and report back to you. I think that is tough for people because everybody has so much going on. But I think that is critically important, and that's what builds trust.
I think that's there's one more question over here. I think that's a great lens for the conversations later today, to really think about prioritizing in that way, because there are many challenges and many things we could do, but consensus and focus, I think, are what you're describing as being the tickets forward, and I hope that some of the sessions we really dig into that issue later today.
And the same thing with community benefit. I mean, again, going back to that, to the extent that we can get some alignment in certain spaces, so it's not like we got $1 and you put 10 cents on 10 different things. But maybe if we put, 50 cents on 2 things, and I join with this other organization, we put both our 50 cents together on that one, and just the thinking, again, there's something about the collaborative group think that is exciting, and that also fuels people when they're tired. How many times, okay, y'all can or cannot raise your hand, but how many times do y'all have the meeting on the calendar? I have a meeting on my calendar like this every other week. And it actually happens to be a long meeting for me. And every time I look at the meeting on the calendar, it's a Monday meeting, and I look at it, I'm like, oh my gosh, I'm in that meeting for 3. It's a long meeting, it's a 3-hour meeting. But every time I go, I'm like, I'm glad I went. I'm glad I'm here, right? And so it has changed over time because I'm just like, I am glad, and this is a meeting that coming in as commissioner, because of the politics of being commissioner, again, the lack of trust between different sectors. This is a meeting that is between multiple sectors in the public health space, right? But again, there rubs. There are things that went wrong in COVID. There's some bad feelings. I get to hear about things that went wrong, right? There's some bad feelings. And so I come into the meeting, I'm like, I don't know anybody in this meeting. There's some bad feelings in this meeting, right? And yet, it's a long meeting, and every time I come out of it, I'm just like, dang, that was a good meeting. And I feel different a year later, right, or 10 months later, the first meeting that I went to was maybe February, I feel different. And I think they feel different, and I feel we're in partnership in a different way. So, and so even though I see it, and I still kind of do that shrug, it's less of a shrug, because it's just that is the energy that sustains the engagement.
That's great. One last question, go ahead, yeah.
Thank you. Don Simonson from Trellis. We're the Area Agency on Aging here in the Metro region. Commissioner Cunningham, thank you for your remarks and really for just this great dialogue today, so appreciate it. So my question for you is, what's top of mind related to older adults and family caregivers?
Well, I would say that there are two areas. Did you say home health? Trellis comes up a bit.
With the Area Agency on Aging, so home and community-based services, meals, rides, caregiver support.
Home and community-based services. So the reason why I'm circling back to that is because it's going to be an unsatisfactory answer perhaps for you specifically. But it's because long-term care, so not home and community-based services, right, but long-term care, assisted living, that comes up a lot. And for good reason, as everybody in this space knows, which is one, hospital decompression is a problem. People, people are there's a shortage of beds, and so it's hard to have people come into the hospitals for, urgent, emergent, or elective needs when you can't move people out of hospitals. Assisted living, SNFs, long-term care are the places where people sometimes have to go, and when they are also facing workforce shortages, this whole pipeline, this backlog. So long-term care also is, as a congregate setting, COVID is still here. Y'all know. It is interesting, I could not get my COVID shot, I'm still a clinician, from my clinic, which is interesting. I have some hypotheses I won't share. But COVID is still here, and the reason I'm lifting that up with our elders and with long-term care assisted living in other settings is when we get, our data is different in 2023 than it was, right, in 2021 around COVID numbers, but still folk still have to report into us, schools have to report into us, long-term care has to report into us. Long-term care settings, and I don't know the denominator, but there are a number of long-term care settings that have COVID outbreaks right now. As you define an outbreak, it's greater than 5 people, greater than 5 cases. So long-term, so that is high of mind, right, in terms of folk who are vulnerable based on age, based on comorbidities, based on in a congregate setting and being exposed. That is top of mind for me. And so part of these COVID monies that exist and the way that I'm stressing people out, and I'm like, can we use any of these dollars which are in an epi lab? But again, if you're from academia, you can get creative with grant writing. Let's try, but for long-term care, right? Because we need to take care of the immediate care needs for folk who are at higher risk. I will say, setting that aside, what I have said and what I have asked for and what I would encourage you to be in communication with our health promotion and chronic disease group is, where is our proposal for healthy aging and for elders, right? Because healthy aging is not just about long-term care. It is about actually living, right, towards the end of your life in dignity, right? Not in isolation, which is a challenge particularly in greater Minnesota, but probably also in the metro for elders. Being able to contribute, right? The wisdom of those, I almost became a geriatrician because I love that piece. I love the knowledge, the wisdom, the stories, the lessons. And so there's so much ways in which, yes, there are health concerns for elders. There's also so much that folk want to do, right? And are vibrant. And how do we maintain that vibrancy and healthy aging at the end of life? So I have asked them specifically. So again, this is not a budget year, and so I don't know what's going to happen this year. But I have said I want to see a healthy aging elders, not long-term care, proposal.
So you will see, I hope you've been looking through the program, many of these themes picked up, gone deeper in, and the aging is one of them that we will be starting on soon. We're going to head into breakout sessions. I'm going to give you guys 10 minutes instead of 15, so a little bit late, but we'll get back on time. But please join me in thanking Commissioner Cunningham for her comments this morning.